Hi, everybody. My name is Maddie Cutler, and I'm a research intern at the Dr. Susan Love Foundation for breast cancer research. And just to start off with a couple of housekeeping items, today's webinar will be recorded and available for online viewing. All of the registered participants will receive a link to the webinar within 2 business days. You can also visit the link that will be included in the chat box, which includes a full listing of all of our webinars. And note that throughout the webinar, we will be dropping some helpful links in the chat box, so make sure you keep that open. And later on in the webinar, we will be having a Q&A. So if you want to submit your questions to the Q&A box in Zoom and indicate which panelist you would like to answer your question, that would be great. And with that, we are going to briefly introduce the foundation and our panelists. So the mission of the Dr. Susan Love Foundation for Breast Cancer Research is to end breast cancer. And as we work towards this goal, we drive collaborative, cutting-edge research with non-traditional partners, shed light on the collateral damage of treatment, and actively seek ways to diminish it and interpret science to empower breast cancer patients. Through our signature program, the Love Research Army, we are committed to encouraging and facilitating breast cancer research in all people, regardless of age, race, gender, sexual orientation, with or without breast cancer diagnosis. And through the Love RA, we provide members with ongoing real-time access to an array of studies. And our aim is to combat the disparities that exist in research by challenging the scientific community to launch studies that are as inclusive and diverse as the people that breast cancer affects. So now just the outline for the webinar today. First, I'm going to introduce our speakers. Then I'm going to present some background statistics and info about breast cancer disparities. Then we'll move on to what you as an audience can do, and we will give you individual action items on how you can support others to mitigate health disparities. Then we'll move on to discussion questions with our panelists, citing their personal experiences in cancer care. We'll have a Q&A for a few minutes with the panelists, and then we'll end with some closing statements. So our speakers today will be we'll be hearing from Erica Stallings, who is an attorney and a freelance writer, and the co-founder of the Young Leadership Council at the Vassar Center for BRCA and Black and BRCA. Also Brett Miller, who is a 10-year breast cancer survivor. He's also the founder of the Brett Miller 1T Foundation and the co-founder of the Male Breast Cancer Coalition. And finally, Miri Mogilevsky, who's a breast cancer survivor and a behavioral health therapist working primarily with the LGBTQ+ community. And just a reminder that panelists will be able to answer questions at the end of the webinar. So you can submit your questions in the Q&A box throughout the webinar, and please indicate which panelist you would like to answer your question. So we're going to start with a bit of background info and research. And I just wanted to state a disclaimer that the research provided should not be interpreted as having a genetic cause. Though these marginalized identities are associated with things like higher breast cancer risk or lower screening rates, we want to emphasize that this is likely due to socioeconomic factors and that the statistics are not causally related to ethnicity or disability status or anything like that. Also, later in the webinar, I'll present a supplemental PDF that we created, which cites each of these individual studies. So if you want to read more about them, you're welcome to by downloading that PDF. So first, we're going to start with being a person of color with breast cancer. And the acronym POC stands for person of color, which means anybody who's not white. There's a positive association between stress, such as racial discrimination, and breast cancer incidence among Black women in the US. This association is stronger among younger women. For instance, women who reported police, housing, and job discrimination are 31% more likely to have breast cancer than those who do not. Before the age of 40, Black women have higher breast cancer incidence than white women and higher mortality rates than the rest of the population at every age. Compared to white women, Black women have fewer oncology visits, they receive less aggressive chemotherapy regimens, and are more likely to discontinue chemotherapy. And triple negative breast cancer is an aggressive form of breast cancer that is known to be associated with a BRCA1 gene mutation. Black women are far less likely to undergo BRCA testing than white women, yet are 2 times as likely to have triple negative breast cancer. This disparity persists even when controlling for factors such as mutation risk, sociodemographic and clinical factors, and associations or attitudes about BRCA testing. Breast cancer is the most frequently diagnosed cancer and the leading cause of cancer-related death in Latinx women in the US. And even though Latinx women are less likely to be diagnosed with breast cancer than non-Hispanic white women, they are more likely to die from it. Latinx women are also more likely to be diagnosed with advanced stage breast cancer and to have delays in starting chemotherapy compared to non-Latinx counterparts. They also receive less information and experience less communication from their physicians during chemo treatment. In contrast to other US ethnic groups, breast cancer rates among Asian American ethnic subgroups are increasing steadily. And breast cancer is the most frequently diagnosed cancer and a leading cause of cancer mortality for all American Indian and Alaskan Native women across Indian Health Service regions. American Indian and Alaskan Native women have higher MIRs, which means mortality to incidence rates than white women across all regions, indicating poor survival after a breast cancer diagnosis. And in one study, more than 54% of patients in this demographic had difficulty accessing cancer care. So moving on to being a male with breast cancer, the incidence of male breast cancer is less than 1% of all breast cancers, but the incidence has been gradually on the rise during the past decade. Men tend to get diagnosed later in life with more advanced stages of breast cancer. More than 50% of male breast cancers are stage 2 or greater at the time of initial diagnosis, compared to only 35% of female breast cancers. Male patients report high levels of cancer-specific distress. Depressive symptoms related to alterations in body image are common. In one South African study, only 6 patients were aware that men can get breast cancer prior to their diagnosis. And the cause of male breast cancer is unclear, but BRCA2 mutations, hormone levels, radiation exposure, family history of breast cancer, and different benign breast conditions play a role. A man with Klinefelter syndrome has a 49% risk of developing breast cancer. People with Klinefelter syndrome are born with 2 X chromosomes and 1 Y chromosome, so they produce more estrogen than people born with just XY. Also, testicular abnormalities are other risk factors for development of male breast cancer, specifically those disorders that cause a lack of androgen production. So there's no significant survival rate difference between young male patients with breast cancer and young female patients with breast cancer. However, younger male patients tend to have a significantly better diagnosis than older male patients. And differences in survival according to race and ethnicity are observed. For example, non-Hispanic Black men have poorer outcomes than white men. And treatment algorithms for male breast cancer have been derived from the treatment of female breast cancer, so there are no treatment algorithms that are specific to men. Men often experience bothersome symptoms from endocrine therapy, and approximately 1 in 4 discontinue treatment due to hot flashes or sexual dysfunction. There are no interventions that have been developed to ameliorate these symptoms that are specific to men. Studies also report poorer physical and mental health in the breast cancer survivors among men. Obesity, diabetes, and activity limitations due to a physical, mental, or emotional problem were more common in men with a history of cancer. In one study, 34% of male patients received no adjuvant systemic treatment compared to only 10% of female patients. Now moving on to being LGBTQ+ with breast cancer. In medical schools in the US and Canada, the median hours spent on teaching LGBTQ+ content is only 5 hours, and 33.3% of schools that were studied reported 0 hours. 30% of LGBTQ+ adults don't seek healthcare services or lack a regular healthcare provider, compared to only 19% of heterosexuals. And among sexual minority women, which is what the SMW acronym stands for, that also encompasses non-heterosexual women. Sexual minority women are at an increased risk of developing breast cancer compared to heterosexual women. However, only 24% of healthcare providers know this. Despite the increased risk, early breast cancer detection screening among sexual minority women is consistently less than early breast cancer detection among heterosexual women. Trans women who undergo feminizing hormone therapy are 47 times more likely to have breast cancer than cisgender men. Despite this, 60% of OBGYN providers are unaware of the existence of breast cancer screening guidelines for trans individuals. As little as 29% of clinicians are comfortable caring for trans individuals. There is currently no evidence-based guidelines for screening among trans individuals. And nearly half of trans men postpone preventative healthcare due to fear of discrimination by providers. Gender nonconformity was associated with an over 40% decrease in the odds of having had a clinical breast exam in the past 2 years. And among gender nonconforming sexual minority women, perceived gender nonconformity stigma and the belief that one's healthcare provider is uncomfortable with one's sexual orientation were also associated with lower screening. So moving on to being disabled with breast cancer, women with physical or mental impairments are less likely than women without disabilities to be screened for breast cancer and may thus be at a higher risk of late-stage breast cancer. The barriers to cancer screening faced by women with disabilities result in health disparities such as later diagnosis of breast cancer, larger tumor size at diagnosis, the consequent need for more aggressive treatment, lower quality of life, and higher mortality. 27.3% of physicians report screening women with disabilities less often than women without disabilities. And some factors of healthcare providers that impact screening among women with disabilities are male gender of the provider, lack of training, working in a nursing home, and feelings of discomfort with disabled patients. And some external factors are the office not belonging to a health network, office toilets not being accessible to wheelchairs, lack of consultation time, lack of assistance, and communication difficulties. Over 24% of women in the US have a disability, and approximately 6% of Americans use mobility aids. Breast cancer survivors with any functional limitations are at a significantly higher risk of all-cause mortality compared to those who have no limitations. So for women with physical disabilities, having a physical disability can make mammography difficult or impossible, and thus persuade providers from recommending it, although there are other procedures that are available. Women with physical disabilities also hold more negative body image perceptions than other women. Breast cancer treatment can result in decreases in bodily satisfaction, potential breast disfigurement, and bodily changes. For this reason, about half of women with physical disabilities report that appearance influenced their treatment preferences. People with intellectual disabilities, on the other hand, are 2.5 times more likely to have complex health needs when compared to the rest of the population. It has been suggested that the reason for lower screening rates among women with intellectual disabilities is due to the provider deciding that screening is inappropriate for some women and omitting them from the list of eligible patients. There's also evidence that clinicians don't seek their consent when providing tests and treatments, and that they often base their best interest decisions on the assumptions of incompetence. Healthcare professionals lack guidance, expertise, training, and knowledge of communicating and caring for people with intellectual disabilities. Similarly, health professionals working in the field of intellectual disabilities lack the specialist knowledge of cancer care management. So this is just some information on what you as the audience can do to help mitigate health disparities. You can be your own advocate during appointments, but I'd just like to note that advocating for yourself can be really hard when you're fighting against a system that wasn't originally designed for you. Even so, these are some helpful tips that could help you through your cancer care. So one thing could be to call your provider's office and, without giving them any information about yourself, get information that is vital to you. Are there any practitioners of color? Is this practice affirming of trans people? You can do this anonymously or using a pseudonym, and then call back to make an appointment if you want. Patient data, such as a disability, is often not shared between medical offices. So when you make your appointment, you can ask that certain information or records are given to the practitioner. If you have an upcoming visit, you can write down all of your symptoms, concerns, questions, goals, and any research you've done ahead of time and bring it with you to the visit. And this is important to do because someone else might not be around. And hospitals have advocates who you can request, who are sometimes known as medical advocates and sometimes they're social workers, but that's not always the case. It's also important to overcome the provider's bias because patients can face tremendous bias, which only increases with intersectional marginalized identities. And lastly, it's your body, and this is a way to take control over it. You can also be an advocate for someone else. An advocate can facilitate a discussion and ensure that all the predetermined questions are answered. The patient can then just focus on listening to the responses. The advocate should also be a note taker and discuss everything with the patient again after the visit. And this is especially important with topics such as cancer, when the shock of the diagnosis can prevent patients from retaining much information. You can also volunteer as a professional patient advocate, especially social workers, and get certified. The resources for certification are going to be in the supplemental PDF, which I'll present in a minute. So first of all, it's important, I wanted to say that the supplemental PDF is can be found in the link that's shown here, and it'll also be posted in the chat, which you can download, and it lists resources and more information on what you can do as an individual to help end health disparities in breast cancer. So here are some action items that are present in the supplemental PDF. You can raise public and provider awareness of disparities in healthcare. You can also, in the PDF, find organizations who are fighting to end health disparities to donate to and share. You can also find social media accounts to follow to get up-to-date information regarding this topic. You can volunteer as a professional patient advocate. They especially like social workers to do this. And as I said before, you can get certified. You can join or volunteer at community health organizations. And importantly, if you're a white ally hoping to advocate for people of color in the healthcare setting, you can listen to those who bear the brunt of racism. You can speak with other white people about how racism affects you and those who don't look like you. You can write a letter to the CDC, the NIH, and other systemic institutions that are responsible for public policy. And there's more guidance and templates for these letters in the supplemental PDF. You can also write a letter to your state and local representatives in support of declaring racism a public health crisis. And finally, if you're white, you can recognize and utilize your privilege, even if it's just speaking the truth when you see mistreatment. Another way that you can help end health disparities in breast cancer is by joining the Love Research Army. You can go to the loveresearcharmy.org, which has been posted in the chat, and register by clicking on the top right corner of the site. So now we're going to move on to the discussion section of this webinar, where our panelists will discuss their own personal experiences with health disparities. So if our panelists want to turn on their video, we can get started. Okay, amazing. So first, let's start off by learning a bit about each of your personal experiences with breast cancer. Erica, if you could tell us how you experienced breast cancer health disparities and privileges firsthand.
Hi, sorry about that. It took me a second to figure out how to unmute my microphone. So thanks everyone, really excited to be a part of this conversation today. I think the topic is extremely important. One thing I just want to clarify, because I think it's really important not to step on other people's experiences, is that I have never been diagnosed with breast cancer myself. I am what's known as a previvor. So I do carry a BRCA2 mutation that I inherited from my mom. I learned that I had inherited that mutation in 2014, and I underwent a preventative mastectomy at the end of December 2014. I think, my mom's story and my own story really touch on a lot of the things that you talked about in your presentation, particularly how privilege and access enable one to be able to benefit from the knowledge of genetic counseling and testing. So where I grew up, my family is originally from North Carolina. We're from a pretty small town in North Carolina called Goldsboro, North Carolina. And I actually looked recently, there are no genetic counselors within 25 miles of Goldsboro, North Carolina. But we were really fortunate in that when my mom had breast cancer for a second time, I was a senior at the University of North Carolina, Chapel Hill. So she actually did her breast cancer treatment there. UNC has a really great academic medical center there. It's actually an NCI designated cancer center. And that's when someone finally recommended that she get genetic counseling and testing. I also realized, even for myself, I live in New York City. I have access to lots of genetic counselors, lots of access to a lot of genetic counselors, access to numerous great medical treatment centers in New York City. And that was really instrumental, both in being able to access genetic counseling and testing, and also really being able to benefit from that information. What I will say really quickly, though, is even with all my privileges, you know, of being a lawyer, of living in New York City, when I was actually having my surgery, when it was time for me to be discharged from the hospital, I noticed that one of my post-mastectomy drains was not working. And I raised the issue to the nurse. And instead of her, you know, calling a doctor or looking into it, she told me I would just have to manually pump it myself. And so it actually took this like almost 3 hour sort of like showdown between like her, my mom, a couple of friends that I like called to come to the hospital for backup, to finally get someone to sort of take the issue seriously. And for those of you who have not had a mastectomy, one of the biggest risks after a mastectomy is getting an infection in the drains. I knew that, and that's why it was so important to me. And so I sort of realized in that moment, like, despite the fact, as I mentioned, that I had all these privileges, like at that moment in the hospital, you know, I really think they just saw me, you know, as a Black woman, and saw me as someone whose concerns did not have to be taken seriously. So as I'll talk about later in the discussion, you know, that experience combined with a lot of research I started doing around racial disparities in access to genetic counseling and testing is how I became a writer, is how I started working with the Vassar Center, and is why I'm here with you today.
Awesome. Thank you so much for sharing, Erica. Now moving on to Brett, I just wanted to ask how you experienced breast cancer health disparities as a man. And I know that you also went through this process with your mom, so maybe you could touch on that.
Yes. So I was 17 when I first found my lump. It was directly below my right nipple. I brought it up to two different doctors during my senior year of high school. And they both had pretty much said that it was a calcium buildup. You're going through puberty, it'll dissipate, it'll go away. It's nothing to worry about. Fast forward about 7 years later, when I was 24, parents had asked me when was the last time I went to go have an actual physical with having health insurance through my job. You know, when was the last time I just went to the doctor in general for a general health checkup? I told them, you know, pretty much about 7 to 8 years. So I set up to go get a physical, and the doctor did all the normal routines for a male's physical, except for checking the breast area because it's not a part of a male's physical. So I had the lump still, and when he was on his way out of the door, I pretty much stopped him to ask him to come back and check that I'd had this lump under my right nipple for about 7 years, and you know, what was his thoughts about it and stuff. And it was just like an immediate, like, quick turnaround. He came right over, he looked at it, kind of felt it, and he immediately set me up for a sonogram, which then led me to the women's clinic. I wasn't told that. I was just told I was going to go get a sonogram. So, you know, not getting like the upfront, like, hey, you're going to need to go to a sonogram, go to a women's clinic, you're going to women, 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 women. You know, it was just kind of shocking. The sonogram led to a mammogram the same day. Right after it, the female doctor there looked at the scans, and she was like, before you go, so you don't have to come back in, redo the scans, take another day or anything like that, waste any more of your time. We'll just do a mammogram real quick. And that should cover all bases. After the scans, it led to meeting with the surgeon to get the lump out. He didn't say anything in regards to it possibly being breast cancer. He just said, based on the time that you had the lump and you know, just it was calcium thing, let's just take it out. The next day after getting the lump taken out is when I was told that it was, I got the call from that surgeon saying that the preliminary pathology reports are that it's breast cancer. I haven't fully read the report, but I'll get through it and get back to you in 3 to 5 days. And it was just, that was pretty much it. There was no like, hey, you know, we need to talk. You need to come in. We need to discuss anything. And so I called and let my dad know. I asked him not to say anything to my mom, as she would just kind of go kind of crazy and ask all these different questions as I was leaving one job to go to another job, and I knew it was going to be busy. 5 minutes go by from hanging up with my dad, and my mom calls immediately, starts asking all the questions. I give her all the information. She goes, you know what? I'm calling the doctor. You signed all the HIP forms for us to talk to him. We're getting this done. It's a great thing that I had my mom there, or somebody. My dad would have done the same thing, but if you ever meet my mom, you will see exactly why I put her in charge of everything. We were meeting with that doctor the next day. So having an advocate, having somebody there with you, taking the information down and understanding it, because being 24 and a male, being told that you have breast cancer comes at you like a freight train. And my mom was there to answer, write all the questions down, answers, and we got, I believe that I got better care because of her, because of my parents, and just the whole process. I everything was like, oh, sorry, we're focused on women. We really don't have much information about men, so we can't help. That was, a couple different foundations and charities, local chapters, and we had the American Cancer Society was like really the only one at the time that had stepped up to the plate. Recently, Dr. Susan Love Foundation has been a huge support, but in helping men. But besides that, we were only given that one, so that's where we kind of started the Brett Miller 1T and the Male Breast Cancer Coalition, to give men that support that they need when they hear the words "you have breast cancer."
Amazing. So moving on to Mary, could you please speak on your experience in healthcare, specifically the healthcare provider's emphasis on fertility, and how this reinforced heteronormativity of your healthcare experience?
Yeah, so I am 29 years old currently. 3 years ago, when I was 26, I was diagnosed with breast cancer. I also found out as a result that I have the BRCA1 genetic mutation. It was a huge surprise to me. So overall, I want to preface this by saying that overall, the treatment I received was excellent. I'm in remission. I'm alive. I'm healthy. I'm good. My oncologist was amazing. Some of my surgical experiences less so, but the important part was that I made it through safely. That being said, I, as a queer woman, and as someone with a complicated relationship with the whole concept of fertility and quote unquote natural pregnancy and childbirth, I found a lot of those discussions to be pretty alienating from the start. One of the first conversations that was had with me, like I think the day of my diagnosis, was like, do you want to freeze your eggs? They really emphasized the fact that chemo might, make me incapable of becoming pregnant, that I would also have to be on medication afterwards that, would put me basically in artificially induced menopause. And for what it's worth, I know that there's been a lot of advocacy in the past from women around this issue. I think we've kind of swung in the opposite direction. It sounds like it used to be that fertility was really not discussed. Women were not warned about how treatment might impact their fertility. But now it's very much like, are you sure you don't want to freeze your eggs? Are you sure? Are you really sure? It was kind of offered to me several times. I did not want to. First of all, I wasn't set on having kids to begin with. Second of all, again, as an LGBT person, I never had the luxury of assuming that if and when I want to become a parent, I would be able to do so, quote unquote, naturally, right? That's not an assumption that we get to make. As a matter of fact, until relatively recently, wasn't even super clear that I would have that right as a queer person in America. So, I already didn't really care about it. I had also just learned that I have this devastating genetic mutation that I would have a 50-50 chance of passing on if I became pregnant, which I wasn't okay with. And there's this interesting conversation with my oncologist where he was kind of, he was clearly trying to be respectful of my wishes. But he was like, well, I feel compelled to warn you that, if you don't do this, you might regret it later. And I asked him, wouldn't this delay chemo? And he said, yeah, you know, by at least 6 weeks, you know, the process of harvesting your egg, oh, that word is even just creepy to me, harvesting your eggs, right? And I was like, well, is there any probability that my cancer would progress while I'm waiting for that? And he kind of said, you know, if we thought that this was going to be harmful to you, we would tell you. But yes, of course, there's always a chance. And I was like, okay, well, in that case, you know, if I am alive one day to regret not having saved my eggs, then I consider that a win. And that was kind of it. But it always stuck with me, the fact that, like, I was so strongly encouraged to do this thing that would delay the treatment of a clearly very aggressive cancer. So despite the fact that thankfully it had not yet spread to any lymph nodes, the tumor was so large that it was categorized as stage 2, and it had appeared very quickly. So I wonder sometimes how the emphasis on fertility might impact treatment, especially for people like me who don't even want it, who don't even care.
Great. So just another question for Miri. Based on your personal experience, how has pain management become more racialized and politicized over the years?
Yeah, so pain management is obviously a really thorny subject. You know, just recently there started to be like full acknowledgement of how overprescription of opioids has fueled an epidemic. I've heard it described as a kind of pendulum effect, where it used to be that opioids were prescribed way too freely for conditions that maybe they shouldn't have been. And now it is extremely difficult to get them, even in situations where it seems that they are warranted. So I had, after I went through chemo, I had a double mastectomy with reconstruction, obviously a very major surgery. I had never even been under general anesthesia before. So I had no experience with surgeries of any kind, or what to expect. I was horrified, I was terrified of it. I spent months just in a state of panic, dreading it. I spoke very directly with my surgeon about my fears, specifically around pain management, because as a social worker, you know, who works with people for therapy, I'm very aware of like how hard it can be to get doctors to take your pain seriously these days. Although the surgeon really reassured me, you know, they're like, we have this multimodal pain approach, like here's what it's going to look like, et cetera, et cetera. None of that was followed. I was starting within hours after this like major surgery, I was denied almost all forms of pain relief. They refused to give me any IV pain medication. They gave me only 5 milligrams of oxy, and only after hours of crying and begging on my part would they give me more. They repeatedly told me things like, I thought you said your pain was only a 7 out of 10, right? That's considered pretty high. They would patronizingly tell me, well, you won't be able to have IV meds when you're home from the hospital. There kept being like pharmacy mix-ups, like they called the pharmacy asking for more medication, but they didn't call them back. It was pretty extreme. My pain never did get under control. For a time, I experienced suicidal ideation. I was in agony pretty much for weeks. Eventually, being a person with thankfully a lot of social support and a lot of like reserves of fortitude, I got through it. But no one should ever have to suffer that way. And I already knew, although I only later started to put it together, that I do feel like my gender and my ethnicity played a role. Unfortunately, as we know, like race and ethnicity and other identity categories impact how doctors and nurses see their patients. For example, just 3 years ago in 2017, this made a lot of news at the time, but there was an outcry about a commonly used nursing textbook from the publisher Pearson. It had a section on pain and like race and ethnicity, where they basically parroted stereotypes. So about Jews, they said, and I'm a Jewish person, they said, Jews may be vocal and demanding of assistance. They believe that pain must be shared and validated by others. It said a lot of sketchy things about other racial groups as well. Some groups apparently believe that pain is a sign from God and must be managed, or some really, really weird stuff. And I don't know if any of my nurses used that textbook. You know, it doesn't really matter. Thankfully, it got recalled. But what I do know is that the stereotype of the hysterical woman, of the complaining Jew, of maybe the young woman who doesn't know real pain because she has never gone through childbirth, I feel like all of these played a role in how I was seen. Because when I talked to other survivors, most of whom were older than me, I found nobody who had the experience that I had. Now, I'm sure it happens, especially to people of color and to other LGBT people, but it was stunning how far outside the bounds of like what I was led to expect it was. And I mean, one of the tough things about bias and microaggressions is that I don't really know if it was because of my identity. I can only suspect, and I'll never really know.
Thank you for sharing that, Mary. So now let's move on to discussing the disparities themselves experienced by marginalized groups. So Erica, if you could highlight some of the research that you've come across related to health disparities for people of color.
Yeah, so I actually had a piece in O Magazine actually almost 2 years ago, sort of focusing on, and I just want to say what I'll talk about is specifically related to Black women and Black individuals generally, just because that's my experience and that's where I sort of have the most, I've done the reading, as I'll say. But really, if you think about it, I mean, pick any condition in this country, whether that's diabetes, whether that's heart disease, breast cancer, which we'll talk about a little bit more, maternal mortality rates, right? We know that African Americans have worse outcomes across the board. Even if we're thinking about the current pandemic that we're living in, currently 1 in 1,000 Black Americans have died from COVID-19. And Blacks and Latinos are 2 to 3 more times likely to be diagnosed with COVID. Now, to go back to the point that Maddie made in her presentation, there's nothing about being Black or Latino, right? There's nothing biological going on that predisposes you to these racial health disparities. It's because of the historic legacy of mistreatment and also underinvestment in communities that minorities live that lead to these racial health disparities, right? And actually a researcher whose work that I really love, her name is Nancy Krieger. She's a professor at the Harvard University School of Public Health. She's even done research showing the historical impact of discrimination on current health outcomes. So she did a study a couple of years ago analyzing triple negative breast cancer rates among Black women who grew up in Jim Crow. Jim Crow was a period of discrimination in the 60s, right? So for Black women who grew up under Jim Crow, they are now more likely to have triple negative breast cancer, right? She also put out a really great study earlier this year analyzing the connection between maternal mortality rates among Black women and people who lived in redlined neighborhoods. And to give some context to that, redlined neighborhoods are neighborhoods where Black people and other minorities, right, were sort of like shunted into those neighborhoods because they weren't able to get mortgages in better neighborhoods, right? And so what are the compounding impacts of that, right? So we know right now that if you are African American, you are less likely than a white person to live in a neighborhood that has high quality hospitals, that has access to those academic centers that I was talking about. You're less likely to have access to healthy food. You're less likely to have access to recreational spaces to be able to work out, right? And so all those things combined, along with the implicit bias that we know exists amongst physicians, really creates the racial health disparities that you see today.
Thank you for that. I was also going to ask if you could speak on the disparities that exist in breast reconstruction.
Yeah, so it's really interesting. one thing that has just been so, I don't want to say eye-opening, I guess I don't really have a good word for it, is, the more that I do talks like this and I do research around breast cancer disparities, you can pick any point in the breast cancer journey, whether that's time of diagnosis, or maybe time of diagnosis when a person is diagnosed, access to treatment, the kind of treatment that they get, outcomes, right? And Black women are negatively impacted at all of those points through the sort of breast cancer life cycle. But even when you're looking at something like breast reconstruction, right, there are racial disparities that exist there, right? So Black women are less likely to undergo breast reconstruction. If we're specifically talking about the experience of BRCA carriers, Black women with the BRCA mutation are less likely to undergo risk reduction surgery. And although the research is still inconclusive, there is research suggesting that that may just be because providers are not having those conversations with them. I can also sort of say at a more personal level, I underwent reconstruction as a part of my preventive mastectomy, and that was roughly 6 years ago. And even now, I have Black women from across the country, because they have found something that I've written or a thing that I've spoken at, who will reach out to me to ask me for what my reconstruction photos look like, because they go to their plastic surgeon's office and they don't see images of Black women, in the reconstruction books, right? So, obviously we're talking about breast cancer disparities, right? There's obviously these really, really huge problems, but, it's just crazy to think that even that's something as small as like not going to a plastic surgeon's office and seeing, women who look like you, who have skin that look like you, right? Who have skin that might scar the way yours is, right? People don't even see themselves reflected there.
That's a super interesting point. Thank you for sharing. So now we're going to move on to some ways that we can mitigate health disparities. Going back to you again, Erica, how can we, both those who have had similar experiences and allies to Black women and people of color, mitigate these disparities?
Yeah, so I think there's a few things that I would suggest. I would say probably if you're tuned into this webinar, you're probably a little bit more active than the average person, right? And so I think one thing that I think people should really push for, so let's say you're being asked to participate on a panel or participate in an article about breast cancer or cancer generally, you should really push the organizers to ask them, like, what's the diversity like on this panel? It may seem like a minor point, but representation in breast cancer awareness campaigns in media about breast cancer is really important. There's a really great study from 2013 done at UNC Chapel Hill that showed that Black women often underestimate their risk for breast cancer, in part because they do not see themselves reflected in breast cancer awareness campaigns, right? So I think that's a really simple thing you can do, right? If you're on a panel, you're going to be in a piece, photo shoot, you should really ask for it and push for there to be like diversity and inclusion. I also know that we are a week out from the election and people are tired of talking about politics. But I do think the political advocacy piece is really important, right? We know that under the ACA, there were states primarily in the South, which primarily have higher Black populations, that did not expand Medicaid under the ACA, right? But we know that in the states that did do that, it did show improved health outcomes for Black Americans. So if you live in one of those states that has not done ACA expansion, right, like push your state representatives to do that. Pay attention to legislation that is going on Capitol Hill. I mean, we're here talking about breast cancer, but there's actually a really great maternal mortality caucus in this Congress who they have been pushing a lot of great legislation to try to tackle the maternal health disparity. And I would also say, if you are also thinking about participating in a research trial, also ask that question of who's running the trial, right? Like, what are you doing to ensure that there is diversity and inclusion in this clinical trial, right? So I really think for people who want to be allies, it's sort of just like always, kind of just always pushing and asking those questions. I would also just say a couple really quickly before I run out of time. There is a really great organization based in Chicago. They're called Equal Hope. They used to be called the Chicago Metropolitan Breast Cancer Task Force. And they have really been able to reduce disparities in the Chicago area through a partnership with both like, academic centers, patients, and advocates. I would encourage you to look at the work in their model. I also think that we should all be pushing for Black women and women of color to be centered in experiences. So another organization I love, the Endometrial Cancer Action Network for African American Women. They actually train African American women on how to be research advocates. They put together guides on how to go to the doctor. They have a glossary of terms. And so I also think that their work could be a really interesting model for how to tackle disparities in breast cancer.
Thank you for sharing those organizations with us. So moving on to Brett, if you could please discuss your experience getting a second opinion and how that could have helped with your breast cancer care.
Yeah, so the first surgeon, after he removed the lump and we met with him, he was very adamant that no matter what, I was going to be eating a double mastectomy. He said research shows double mastectomy, and this is what we're going to do. And so I had asked him, how many surgeries has he performed that not for? I would have been his first male, and he had performed it on maybe a dozen females before as a general surgeon. I didn't, during the entire process, I didn't feel like being. I knew that it was going to be there, but I didn't really feel like being a guinea pig to too many of these doctors. So, and just hearing that I was going to have a double mastectomy, and being a pool manager at a country club, and there's times that I have to have my shirt off and get in the pool. Like, what would others, what would people think? And so we met with the second surgeon, and he too had said a double mastectomy, but said that we could come back to do the left side. Since it was the right side that was effective, we can schedule the left side for a later time, and was very open about it and to different options. He had performed the surgery on a dozen men before me, so knowing that he's got some experience in that was reassuring. At the time, he had told me that he could try to reach out to one of those men if I had any questions, but that most of them took time off work, had the surgeries, healed up, went back to work like nothing ever happened, and don't really talk about it much. And at that point is when he discussed with me that if it was something that I was willing to share my story, that he thought that I could help more men out. And following that, we set up for the single mastectomy for the right side. In the time in between, I did meet with a plastic surgeon to discuss reconstructive options. He's one of the top surgeons, plastic surgeons in the area, and he said that he's never performed one on a male. He's never done a reconstructive for a male. He didn't think that it was completely out of the realm of doing it, but that he would need to do some more research on it and kind of get back to me on it. But it was possible. But just hearing another doctor say that it would be the first time that he perform it, nothing against him, but I was just like, you know what, this is this is part of who I am now. This is my scar. This is kind of like the story. This is the telling point, and this is what I think is going to help others become more aware that men can get breast cancer, the physically showing, rather than showing a reconstructive and then trying to explain everything regarding that. So between those two, those plastic surgeon and then my surgeon, those were the reasons why we started doing the foundation and the coalition. But a second opinion I think is warranted, or a third opinion. You're your own best advocate. You know your body better than any other doctor. So if you feel that something's wrong, go to the doctor. If they tell you that it's nothing, don't worry about it. It'll go away. And you don't like that answer, go get a second opinion. I've had another survivor in the area that it took the third doctor before she just said, no, I'm not leaving until you figure it out, because her lump was up near her collarbone. And the doctors were just brushing it off like it's nothing. Ended up being stage 3 breast cancer. So being your own best advocate, knowing your body, and getting a second or third opinion is definitely warranted.
And Brett, if you could just speak to how allies can help support men with breast cancer.
It's being more welcoming. You know, at the beginning, like I said, there were two different charities, foundations that we reached out to that we were told that it was, oh, sorry, it's, you know, well, we only focus on women. I get that it's a personal disease. You know, for women, it's a lot going through because it's the possibility of losing a body part that's associated with, you know, just being a woman. Um, you know, I get that, but you know, it's still you know, being diagnosed as a male, a deformity that's going to be in my body as well. So being kind of shunned away was very, you know, it was hard. Um, but you know, the biggest thing that we, you know, now is I'm a person. It's not just a women's disease. It's not a men's disease. It's a people's disease. So, you know, being the more inclusive, educating the doctors, you know, making sure doctors are aware of it. We were at a very large oncology conference a couple of years ago, and we had doctors from all over the world, and a few of them just walked up and kind of laughed at our booth, being like, "Men don't get breast cancer." You know, medicine changes every day. You know, doctors need to be educated as well as society. So, if we can drop this stigmatism of women and change it to people get diagnosed with breast cancer, then I think that it would help. And the advocates, the education and awareness in men and women and the youth, you know, knowing your body. If you see something, you know, feel something, say something.
Thank you. And finally, moving on to Mary, if you could just let us know how both those who have had similar experiences within the LGBT community and LGBT community allies can help mitigate breast cancer disparities.
Absolutely. So I'll note, first of all, you know, there are like LGBT community and health agencies working on this in a lot of ways by offering information, offering screenings. The organization I work for in Columbus, Equitas Health, focuses on offering what they call chest screenings to the community. So because for a lot of non-binary and transgender people, the whole concept of, you know, breast checks and like breast cancer can be very alienating because those aren't the words they use to describe their bodies. Referring to it as a chest screening and making it clear that it's for people of all genders can help increase access, which incidentally, speaking to Brett's point, that also has the positive effect of including men more, because then it's not about breasts and it's not about women. So those are things that are already going on. But in terms of like what individuals can do, first of all, like being aware is really important. So I actually waited longer than I should have to go to my primary care doctor and let them know that I'd found this lump. And honestly, I don't really even know why I did. I think in my mind, maybe because I'm so young, it seemed so impossible that it would be anything serious that like part of my mind knew you should probably check this out, and the other part of my mind was treating it kind of like when I know my car needs an oil change, but it'll probably be fine if I just wait a few more weeks. But actually, my partner really kind of pushed me and was like, "Hey, you really need to go get this checked out." And my partner is someone who didn't have any personal experience with cancer of any kind. It can be really difficult to have that conversation with someone you're close to, but it can save a life. In order to do that, though, you have to be informed and you have to be able to help them find an affirming place to go get healthcare. So wherever you are, like know what the options are in your community. Know if there's an LGBTQ like health center, or if not, if there's an agency that does trainings for like local medical providers, and then see if you can find out which ones have been trained, which ones use like their patients' chosen names and pronouns, right? Rather than like increasing those barriers to getting care. And to know that if there are people in your life that might benefit from that information, be willing to have those tough conversations. It's never easy to say to a friend like, hey, I know it's none of my business, but it sounds like there's some stuff going on with your health and I'm worried about you. Could I maybe help you, find somewhere to go? I feel like you will always be glad that you spoke up rather than said nothing.
Okay, well, thank you all for sharing your personal stories. I think I speak for everybody in the audience when I say I really appreciate it. And it's so useful being able to just listen and hear from people who've actually had these experiences. So at this time, I'd like to take some time just to have you guys answer some questions from our viewers. So if anybody in the audience has any questions that they'd like to ask, please put them in the Q&A box. We'll try to get to as many questions as possible, but we might not be able to get to all of them today. So the first question is for Brett. Can you elaborate on support groups for men with breast cancer, and were you offered breast reconstruction, or was that something that you had to find on your own?
So the support groups, I didn't have anything from the get-go. That's where after meeting with the surgeon and my doctor and them saying that they see something in me if I was able to share my story, then I could help others out. So that's and hearing that and just hearing that many men don't discuss it, don't talk about it, and act like nothing ever happened. That's where I decided that, with the help of my mom, to start the Brett Miller 1T Foundation, where we focused on building the awareness in the youth and men in general. That was in 2010, and then in 2014 is where we evolved to the Male Breast Cancer Coalition. I co-founded that with Sherry Ambrose out of New Jersey, and we are now essentially globally. We have men from all over the world sharing their story on our website, coming to us for help, support, resources. We have many doctors on our advisory board that will answer questions day and night for any of our men that have don't feel that they're getting the proper care. So we are just a very large resource for all men. We have, I want to say, hundreds of links for men to get resource, to reach out to other advocates near them, or just somebody to talk to. We have breast self-exam videos and cards that are both for men and women when you print them out, and they're done in 20 different languages. So it just kind of helps everybody out. So that's our website's melebreastcancercoalition.org.
Thanks, Brett. One more question for you. Do you find it hard to help and reach other men because of the stigma attached with breast cancer as being typically affecting women?
Yes. Most of the men that get diagnosed reach out to us, but I feel that some of them don't reach out at the time of their diagnosis. It takes them quite some time to kind of wrap their head around the diagnosis of hearing you have breast cancer, because they hear breast and they immediately think women with boobs. So it just takes a little bit for men to wrap their head around it. I know some consider or call it chest cancer or pet cancer. To me, that just kind of clouds the water on everything. It's still breast cancer. It's your breast tissue that's being affected. It's being diagnosed with the cancer. So it's just if we can have the more inclusiveness. I don't know if it's reducing the color amount of pink, if it's adding some blue to it, but I think the biggest thing would be changing it from women to people. All the pharmaceutical commercials that say if you're a female diagnosed with stage 4 metastatic breast cancer, this drug's for you. Well, we have a lot of men that are diagnosed with stage 4 metastatic breast cancer, and they're actually taking that drug, but it's only because of the help that we have done and or their doctors have done to get them onto that drug, because everything says women. So we just need the inclusiveness to make men feel more welcome in this community of breast cancer.
Okay, I don't see any more questions. So I guess with that, we'll move on. And does anybody else want to make any more comments before we conclude? Okay, great. So thank you all for coming. Today's webinar has been recorded and it will be shared with all of you within 2 business days. If you have any questions that were not able to be answered today, or you would like to get in touch with either the foundation or the panelists, you can use the contact information that's on the screen right now. Again, I just want to thank all of our guests and panelists for joining today. This is a really important topic, and I'm really excited that we had this webinar. And I encourage all of us to continue this conversation with our peers and colleagues and families. We really appreciate you being here, and we hope that you're staying safe and healthy during quarantine time. Yeah, so thanks everybody.
Thank you.
Thank you.